Well, thank you very much for having me here today. Let's go like this. And these are my disclosures. I'd just like to, again, give Dr. Siraj another round of applause for a great speech. Unfortunately, it's all fake news. And it's easy to get caught in. This is a young, charismatic vascular neurologist. You can see him here receiving this award from the American Heart Association. He's very, very passionate, very, very charismatic. You want to believe him. You really want to believe him, and I want to believe him. The problem is, it's a little bit of a promotion here. So Dr. Siraj wants you to believe that doing mechanical thrombectomy on this is going to be a good thing for the patient. I'm going to go back again just to make sure we got that. Dr. Siraj wants you to believe that mechanical thrombectomy is going to help this patient. So let's get into the nuances, because there are a lot of nuances here that are very, very important. First question is, how are we actually measuring core? There's many, many ways to measure core. These are all, at best, estimates of core. We know we can use CT scan and identify aspect score, but we know that CT scanning is specific but not sensitive. So there can be a wide variety of core volumes, even within a given aspect score, a single aspect score. CT perfusion, we used to use CBV quite frequently. We do have other measures of CBF now, less than 30%. However, again, these are just rough estimates, and we know that there can be a lot of variability within that as well. And even our quote-unquote gold standard of MRI, we know DWI can be reversible. So do we really, really know where core, when we're talking about these large cores? Very, very nice papers over the years looking at CT perfusion. When we have estimates on CT perfusion of large core volume, but the CT scan looks okay, those patients can still end up with very, very small final infarcts when they're reperfused. So whether or not we're truly talking about large core in a lot of these studies is a questionable measure. Even when we talk about, and this is a slide from Dr. Sai, and looking at data from Stanford, we have definitely, CBF of less than 30%, but the stated goal there is to underestimate the core because we want to take more patients to intervention. And so, again, in all of this discussion, we have to be a little bit cautious that are we really, when we're talking about core, what exactly are we talking about? Another nice slide from Dr. Albers showing that there can be a lot of discrepancy between CT scans and CT perfusion. And so this also depends on where you are in the time frame of the patient. If you're very, very early on after it with a stroke, CBF may be or CT perfusion may be a more accurate estimation of it, but later if there's, there can be changes in that can allow the CT to actually be more accurate. So all these things are very, very important as we start to discuss whether we should treat large core. And then, when we're talking about large core, are we really actually truly talking about large core? We're actually probably talking about more about medium core. We have decent evidence now that I think, low aspects, if we're talking about aspects of 0 to 2 or greater than 100 cc's of infarct, those patients aren't doing well. We know that patients who are greater than a 6 or core of less than 50 cc's are likely going to do well. It's really, again, this 50 to 100 cc, that's presently where the question lies. And even within that, if you have only a 50 cc infarct, 51 cc infarct, and a large mismatch, do we really have equipoise in that situation? Do we really feel that that's a large core? I think most of us would argue that really that's actually a really good core, small core, and we should be going after those patients now. So it's the greater than 70 cc's that we're really, really talking about. And very, very nice of Dr. Siraj to actually tell you all my points already and prove my point. But in this case here, again, only 8% of those patients are getting MRS of 2. Is that 8% really worth it? I think that's a question that we have to ask, especially when we're talking about a very resource intensive and we're hearing the concerns about burnout. Again, looking at this is from the Hermes collaboration. Depending on what you're looking at your MRS, if it's 0 to 1, 0 to 2, or 0 to 3, we can see as we're getting up into those large core numbers, those lines start to cross, and there's a lot of uncertainty about whether these patients actually benefit from the procedure or not. SELECT, again, congratulations to Dr. Siraj, a very, very nice trial, and we should commend him for the work that he's done on that, but we got to be very, very careful not to overemphasize the results of this trial. It is a prospective cohort, but it was a retrospective analysis. It is not randomized, and that's very, very important because, as stated in the paper, the medical management group did present later and had larger ischemic core at the baseline, and so that immediately can sway the result away from or towards the interventional arm. Majority of patients also had core perfusion mismatch, so that mismatch also may be a very, very important factor that we need to consider. And if you look at the paper, only half actually had a core of greater than 70 cc's, which is, I think, where our real question lies. So if a lot of the patients had cores between 50 to 70 cc's, again, we have to ask ourselves, is that truly the patient population that we're interested in? And at best, this is a hypothesis-generating study, very, very important study because it's helping to inform us as we go into these clinical trials, but we got to be very, very careful not to get overzealous about it. Again, the overall result, be very, very cautious with this because after adjustment for confounders, that significance was lost. The adjusted MRS there was 3.95. You can see that that confidence interval crosses 1. We did see some very nice signals there, smaller final infarct volumes, and it did appear to be safe, so no overall difference in hemorrhages, neurological worsening, and mortality. But again, if we really start getting into those what we would consider large core patients, greater than 100 cc's or aspects 0 to 2, no patients had good outcomes, and there may be safety concerns in that aspect as well. Again, this is where it comes into the nuances. This is from the SELECT paper, as he showed you, but when we're talking about it, again, the 50 to 100 cc's, if you're very soon after the onset, you might be able to get some good outcomes in those patients, so maybe it's worth trying in there. But if you get further out, you're seeing a lot of red on these slides, and that means the further that we are out, the larger the core, the less chance we are going to have a good outcome. The aspect's a little more variable, but again, aspects, I have some questions about whether or not truly were there a lot of good core patients actually mixed in with that. I think location also matters. From the data that's out there, large infarctions are going to have a much different impact depending on where they are in the brain. Right hemisphere does seem to be able to tolerate larger infarction than the left. Some nice data here. You can see, especially at the aspect score of 4 or 5, those right hemisphere patients seem to do a lot better with, even though they may have a larger infarction. So it comes back down to selection. Picking out the right patients is going to be very, very important. And again, the older we get, the less infarct we can tolerate. There was a study by Tonetti saying that good outcome, and those over age 90, for example, were only found with volumes less than 10 cc's. And of course, I get all my information now off of Twitter. And so you can see here, this Tudor-Joven rule. 100 minus the age is the core you can go in and expect a decent outcome. So age being a factor in how we select patients also becomes really, really important. Follow me on Twitter. Again, just some graphs. This is also from the Hermes analysis. Similarly, the older that a patient gets and the larger their core infarction, the less and less chance there is of good outcomes. So really important nuances to this discussion. We cannot get zealous and just say that every large core should be treated. He already mentioned about this issue about do no harm. The larger the size of infarct at baseline, the more risk of that hemorrhagic conversion. So I won't spend too much time on that as well. Lastly, I just wanted to bring up again this idea about the resource investment and burnout. We are in a situation, I think it's being discussed more and more openly, which is great, so we can actually tackle this problem as societies and as groups. But this stroke call burden is a significant on all of us that treat stroke as interventionalists and stroke neurologists. And so we have to be mindful, and especially, part of the issue is the work hours and the fact that we're in the middle of the night, but remember, burnout is also tied to people feeling passionate and value in their work, and if we end up taking a lot of patients that really don't have a chance at benefiting and we're seeing poor outcomes resulting from that, that's going to very quickly push this burnout question in a bad direction. So, again, we could be cowboys in all this, like Dr. Siraj would like us to be, throwing around our catheters every which way, every direction. On the other hand, you may not want to pontificate as much as, say, someone like I would. So the best thing to do is to be like this guy here, very, very intelligent, smart, and thoughtful, but when action needs to be taken, you get the job done. So again, don't believe the hype. Randomized trials are needed in this. This is really a situation where I think there is very much equipoise. Outside of clinical trials, I just urge people to be cautious. It's not that you can never take a patient with a large core, but try to select out those patients that can benefit, the younger patients, right hemispheric infarctions, those that are very soon after their time of onset. There may be still opportunity to get benefit there. You should take those patients, but be cautious about applying this therapy because there could be harm being done. I appreciate your time. Thank you.